NSIC, Nigerian Society Protection Control. Today, we have a good topic ahead of us to be discussed. We also have a speaker, even though I'm not sure he has joined yet, but I will go ahead to make the necessary introductions while he. And it's my pleasure to welcome everyone to today's section. And our topic today says IPC Professionals, the frontline against AMR, empowering action through knowledge. And today, as we got as healthcare professionals, advocates, and as well as stakeholders, united to addressing this critical public health challenge of our time, this topic is actually very, very, very timely. And as we all are aware, AMR threatens the very foundation of modern medicine. It endangers our ability to treat infections, perform routine surgeries, and also manage chronic illnesses effectively. So yet, as daunting as this challenge is, it also presents us with an opportunity to act decisively as well as collaboratively. And this section is going to be centered on the vital role that we professionals play as frontline workers to fight against antimicrobial resistance. And our collective knowledge, expertise, and commitment are most important tools in addressing this threat. So today, as we engage on the discussions and deepen our understanding about AMR, and also equip ourselves with insightful knowledge to strengthen our efforts, I want to welcome each and every one of us, and thank you very much for being part of this conversation, and I look forward to a full discussion ahead. And also, please, while the section is going on, if you have any questions, please, we really, really appreciate that we have those questions, and they will come towards the ending of the section. I will go ahead to introduce our speaker. And let me check if he has joined. Dr. Nemeka, please confirm that you're on the call. Oh, yes. Dr. Nemeka. Oh, good to see that you're here.
Yeah, good
Welcome.
afternoon. Yeah, thank you.
Good afternoon. Good afternoon. Good afternoon. We're very happy to have you in today's section. I'll go ahead to introduce him to every one of us. So Dr. Nemeka Sebudu is a public health physician. He's a chief resident of the Department of Community Medicine, Nnamdi Azikiwe University Teaching Hospital. He's part of the IPC team of the NAUTH. He was a member of the scientific expert panel of Shelina Healthcare, and also was part of the technical working group for drafting their AMR national protocol. He has trained doctors, pharma committee members of antimicrobial stewardship programs in many facilities, tertiary hospitals on AMR. He's also actively engaged in advocacy to combat AMR in all settings. So we're really, really happy to be here. Welcome once again, Dr. Nemeka, and you have the floor now. Thank you so much. Would you want to, I guess you want to share your screen. Please go ahead, you have the floor. Thank you.
Okay, good afternoon, everyone. Just a second. Okay, is my screen visible?
Yes.
Yes, sir.
Okay, just a minute. I need to minimize a lot of things here. Okay, good afternoon, everyone. Please, let's confirm that I can be heard.
Yes, we can hear you, sir.
Yes, we can hear you.
Go ahead.
Okay. Yeah, apologies for coming in a bit late. I had a lot of technical issues coming in. But that being said, it's a pleasure to be in the midst of healthcare workers, senior colleagues, and colleagues. I understand that it's more inclined to IPC, the diploma program that CCAPS is involved in. So I want to just start a discussion. I'm not going to be able to pull through everything that is expected But what I will do today is steer everyone's heart to the direction the world is headed to, and I would actually welcome engagement at the end that will bring out more information. So today we'll be looking at AMR, so to say. So we're trying to find out the role I have to play. So IPC Professionals, the frontline against AMR, antimicrobial resistance. So we're empowering action through knowledge. Very apt, I would say. So that's my outline. I'll definitely move more than this, but this is what I intend to run through. Then we'll discuss at the end. So let me give you a background. Now, we're talking about AMR, full definition of full meaning, antimicrobial resistance. Now, when you get to antimicrobial resistance, we're talking about antibacterial drugs, antiviral drugs, antiparasitic drugs. So basically everything that we basically use in combating infection. So I've written antibiotics here because most times that's what most people mistake it for, but that's not exactly what it is. So antimicrobials happen to be the best discovery of the 20th century. If you go, I'm an epidemiologist in training. If you go back and look at the world population and check the timeline, look at the way the population has actually increased and reduced over time, you would find out that when we had serious dip in the world population, it was because of great plagues. You know, there are many of them that have happened, the Black Plague, all of them, bubonic plague, and even the COVID-19. If you look at the world population after the pandemic post-2021, you notice that there was a great dip in the population of the world. So the antibiotics actually helped mankind to combat loss of lives due to infections from antibacteria, from bacteria, as well as from what they call fungi, as much as we talk of antivirals. So the question is, why are we playing with what we consider to be our best invention? That's what the focus of this discussion is. So man's activity has actually affected and has actually given rise to antimicrobial resistance. We get to understand what it means. When we're talking about misuse, a lot of people go over the counter. Every febrile infection is considered to be a parasitic infection, and lo and behold, you pick up an anti-malaria. And to add it, those over-the-counter patent dealers would normally add called an antibiotics that most likely they do not complete the full dose. So you're doing all these things without knowing what you're treating. So the use and misuse. Now, I just talked about getting a prescription over the counter, and because you only cross over there, all they care is the funds you're going to give them. So you say, I don't have 50, I don't have 5,000, and the drug, the appropriate dose should be 5,000. So what they do is just cut the dosage and give. So we'll have on the dose, then overuse. Everything in our balance is enteric fever and malaria. These things have actually prompted the increase in the development of antimicrobial resistance. Now we now have superbugs. So antibiotics and antimicrobials are no longer being manufactured. They can ask those in the pharmaceutical firms. Newer versions are now coming out. So just like we have a classification we call the AWARE classification, the restricted group, we've gotten to the head bridge. We can't do a lot more. So what we are doing now is shooting ourselves in the foot, because if we misuse the ones we have around, we will have organisms come up that are way stronger than the ones we have in our vicinity. So the question, the focus is infection prevention and control measures. That's key in combating the rise of AMR. This is what we'll find out as we go down. So let's look at the magnitude. How severe is AMR? I know most of you haven't heard. If you go to the WHO website, you find these details there. The issue here is a problem of information. If you tap your colleague at work, nurse, doctor, pharmacist, and you ask them, have you heard about AMR? the first thing they will ask you is, maybe I've heard. The first they will say is, maybe I've heard. Then go a little further and ask, do you feel it impacts your life and my life? And the question will be, how do I know that? So that's the issue. But the truth in balances and in crimes where we study, we found that the WHO has found that an estimated 10 million people will die of diseases related to antimicrobial resistance. 20 is what we hope to change by having this discussion today. Africa is most hit. 40% of these deaths will come here. We don't do a lot of due diligence with research, we just consume. AMR superbugs are already responsible for 1.2 million deaths. So people say, how can you prove that? You're not looking for it, but it's out there. So this data is factual as WHO. So I just want to read a report, permits me. Now, the former director of WHO, that's Margaret Chan, said antibiotic resistance will lead to the end of the modern medicine as we know it. I just made something clear. If you do not have any other organism, if you do not have any other arsenal in your with you to combat superbugs that are coming up, we'll revert to the issue to the previous seasons of plagues when whatever infection comes out wipes out almost half of the population. Just look at the picture. That's a microorganism giving out a knockout blow to the best thing we have on our hands. So the question is, how does this actually happen? Towards in the next few slides, I'll be able to explain them, but let me just finish. There are organisms popping up everywhere in all settings. You have MRSAs, that's antibiotics, we know, cephalosporins, third generation, fluoroquinolones, the Cipros, theofloxacins, all the ones you have 50% resistant, meaning that if I were to use this to routinely treat my patient empirically, when I mean empirically, what I mean is I've not sent the sample to the lab. What it means is that I am likely to have a 50% failure rate. That is alarming for a physician or for a healthcare worker. And that's because we have not worked or looked at the issue of antimicrobial resistance, 50% resistance to third generation cephalosporins to Klebsiella. These are very, very serious infections that we are playing with. I'll move on. So the question is, antimicrobial resistance, what exactly are we talking about? So I will explain this. You have organisms that routinely respond to antibiotics in their proper dosage, duration, no longer responding to that. Why? Because over time, such individuals have been exposed to suboptimal level of polar antibiotics. I'll give you an example, and it's more like an analogy. If I know that by 4 p.m. every day, that a burglar will get through my window, what does that do for me with regards to preparedness? All I need to do is set up something to take care of him when he comes in by 4 p.m. That's exactly what happens with using suboptimal dosage of antibiotics. Everyone picks up any antibiotics. We're all the ones prescribing for ourselves without doing the necessary sensitivity and culture. So what happens? The organism is initially not the problem, and you expose it to something that should take care of it. It sees it in a dosage that is not even adequate. What it does is that it takes note of it and changes its defense system so that when next you take that antibiotic, it will not have any effect because it has already taken note of the defense of the antibiotic. So this is exactly what happens in AMR. The organisms mutate, they change because we've misused, underused, and overused antibiotics. So why have we caused AMR to rise? So let's just look a little bit at it in detail. So lack of adequate health services. The problem here is that it's a system issue as much as an individual issue. We have health systems that are not functioning well. So people are not willing to get to the hospitals, or if they get there, they cannot afford the expenses. So what you do is that you have alternatives popping up everywhere. Everyone now is a doctor in quotes, or a nurse, a healthcare worker in quotes, prescribing, and there are no legislations over most of the communities, the places, the Pharmaceutical Association of Nigeria, our Society of Nigeria will tell you that, 500 meters between this pharmaceutical firm and the other one. Nothing like that happens. There's no regulation of patent medicine dealers. You have drugs that should not be, that are within the WHO classification. Like I said, there's a classification called AWARE, access, restrict. These are drugs that you give only when they are in the public sphere. So the young ones or the people that are not experienced, that do not have adequate knowledge of when to give this particular antibiotics or antimicrobial, end up giving it out just for their own economic benefits. So we have lack of adequate health services. We have suboptimal water and sanitation. I will get to that. The issue here is people have misused antibiotics. So we have antimicrobial resistance popping up. The problem is that the spread, that's where IPC comes in. The spread of infection should be curtailed. Yes, we know, okay, let's assume we have a focus of AMR resistant, antimicrobial resistant in a hospital, few cases. But the issue is that when we have problems with how to take care of the hygiene, and in that setting, those that are vulnerable ultimately pick up that infection. There was this video I watched while we were doing our training. You see someone pick up this infection because the person didn't do proper hand hygiene, puts it on the phone, and the other person comes, picks up the phone, contracts the particular organism, rushes to attend to an emergency. Unfortunately, is an immunocompromised victim. You see the lineage, you see the spread, and without proper IPC, we cannot checkmate it. So these are the things that have actually led to the rise of AMR, inappropriate use of antibiotics, both in human and food and animals. I must pause and comment. Most of us think that only medical people, doctors handle antibiotics. Please just take a walk to the next poultry shop by your side and watch closely what happens when one of them develops a cough. You see the owners of such settings go and purchase antibiotics that we consume as humans, and we give them to animals without paying attention to the appropriate use. So you have, without knowing it, you as an end user, you buy poultry, you're consuming antibiotics, a particular livestock, and you consume it. So that's one way. You might not have gone to buy the drug over the counter illegally, but you have consumed legally food that has been dosed with antibiotics. So we have to factor this in as one of the major issues. That's why when we look at how to mitigate, we'll see it's a multidisciplinary approach. As much as we are talking to healthcare workers that work in facilities, the education does not end in the healthcare facility. So we've talked about there are gaps in research and development. So I'll move on. I've talked about self-medication. This is one big issue. Everyone here is skilled in prescribing medication, not just for yourself, but for even those that are not your family members. And what do we have? Because like I said, there are drugs that should not be used without sensitivity, without proper sensitivity. There are drugs that should not be taken suboptimally. We have people prescribe drugs, and these drugs are easily gotten over the counter, unlike in other climes when you have regulations. So all these things combined give us the big problem we have with AMR. So in Nigeria, it's a very, very wonderful picture. Don't mind my language, you're saying wonderful. I believe we can change the narrative. You have the highest prescription rate in Nigeria. These are studies done in Nigeria. You have the third highest percentage of antibiotics. Not every flu symptom requires a patient to take antibiotics, but the first thing that happens is that, oh, mommy, I'm coughing, or daddy, I'm coughing, and next thing is capsule amoxicillin, capsule erythromycin. You have these people taking drugs that for antibiotics for things that should be viral infections. So the big problem is not exclusive to other clients. It is also in our setting. AMR is something that has crossed all continents everywhere. IPC is key to mitigating it. So I want to just give you the big picture of AMR. So the WHO has over time seen this as a big public health issue. So in 2015, they had a global action plan on AMR, and these are the strategies. Please take note, you will see where IPC falls in. I'm just giving you a background. So the first thing they said is we are going to combat AMR. We need to work on awareness, and people need to understand what AMR means, that antimicrobial resistance. So the only way you can education, I'm doing that now. In educating people, you have to effectively communicate. The other thing is that we need to strengthen knowledge through surveillance and research. Now, the issue is this: if you do not search for something, most likely you will not find it. If you check most of our facilities, we don't collect data. If I ask you, what, as an IPC personnel, what is the most common ailment, or let's say disease, with regards to antimicrobial infection in your facility? The question will be, I've not done anything about it. There's no data. We don't have autobiograms in our setting. So you don't have any, most people, it's not their fault, they don't have the capacity, and most people are not inclined to research. So to combat AMR, even as IPC professionals, we need to key into this. Now, the third objective is where we fall in straight up: reduce the incidence of infection. When I get to the role of IPC proper, we understand why this would help drop the incidence of AMR, the prevalence of AMR. Now, to reduce the incidence of infection, we need to handle water, sanitation, and hygiene. I know we're very clear on that. There's no way you do IPC without water in a facility. And we have infection prevention and control, all the components, all the activities, all of them work towards reducing the incidence of infections. You now have, and what infections in facilities are we talking about? Healthcare associated infections. Now, for the animal, for those in animal, that's those involved in the animal setting, we talk about animal health prevention and control. That brings up a concept I forgot to mention. Because we know that AMR, antimicrobial resistance, cuts across both the human, the environment, and as well as the animal sectors, we have a concept WHO has put forward, which is what we call One Health, meaning that I know that for me to stay healthy as a human being, I need to make sure that my environment is in a stable and a healthy state, as well as the animals. So it's a concept that cuts across everyone. Now, we need to optimize use of antimicrobial, really our focus today. This is for those under the antimicrobial stewardship communities, but good to know that we need to get people to bring up regulations, and it should not just be for healthcare workers, it should also go down to the fed. We also need to talk about sustainability of investment in controlling antimicrobial resistance. I want to paint this glory picture. If we do not protect what we have through regulation or through research, the burden of AMR infections will continue to increase. You will have people coming to hospitals healthy and pick up resistant organisms that we cannot handle with our antibiotics. It will affect healthcare, it will affect patient outcome, it will affect the community as a whole. So let's move down to why IPC is focal. Why is IPC a frontier, a major frontier? Why are we IPC practitioners a major frontier in stabilizing health system and combating AMR? There are three pillars here. We've looked at antimicrobial stewardship, while our focus is IPC. You can see that there are three of them. You need to get the medicines and patient safety sorted out, but IPC is key. So let's get into it. Sorry, I had to put up this definition so that some people have a little knowledge of what I'm saying. So stewardship, most of you will hear that. Now, I want to point out clearly, in most facilities that I've visited, the antibiotic stewardship committee is domiciled in the IPC team. So most times you can't extricate both of them. So it's important to know the definition so that when, as an IPC practitioner, you are exposed to this, you need to know that an ABS is a systematic approach to educate and to support healthcare professionals to follow evidence guidelines in prescribing and administering antimicrobials. The essence of antibiotic stewardship is to make sure that we do not have AMR, antimicrobial resistance, continue to increase. So that's exactly what this definition is. So let's look at IPC. We're back home. So what is IPC according to WHO? Is the scientific approach. I made sure that I broke it up. And practical solution. We're not talking of highfalutin thing. We're talking of evidence-based things that we've done and we've studied, and we see that these things are effectual. They are practical. They are things we can do. They are high and low-hanging fruits. Whichever one your hands get to, the most important one is to carry them out. They are designed to prevent harm caused by infection to patients and healthcare workers. We're all human beings. As healthcare workers, we're not people that have 7 lives. But it is important to know that IPC is key in the taking care of AMR. Now, I said it's a subset of epidemiology. When we talk about epidemiology, we're talking about things that affect that determine how infections pop up wherever we are. It also serves as an essential function in infectious disease. Let me just move on so that we can get the clearer picture. Now, the focus of our discussion today is IPC in AMR. Now, I know that I have a mixed multitude. I have people that are doctors, nurses. I have people that don't even have an idea of what we're talking about. But the key thing here is that infection prevention and control is a critical component in the fight against AMR. I want to point this out to us. When we talk about antimicrobial resistance, we talk about misuse, disuse, underuse of antimicrobials. Why? Because there's an infection. But if there is no infection, definitely we will not have need to take antimicrobials. That's where IPC comes up. Our focus as practitioners is to ensure that you do not, in the first place, contract infection. So you see importance of IPC in taking out AMR. If IPC practices are implemented, if we follow through with all, if we follow through with all the practices, hand hygiene, environmental sanitation, care of the linens, what we will have. Hello? Okay, sorry. Okay, so
please, Dr. Issa, please mute your mic, please. Thank you.
Okay, so sorry for that. Point paints the picture so that this is what, if we end the lecture today, I'll be glad that I've spent my time explaining how does IPC factor in the fight against AMR. The first thing I want you to know is that if you do not have an infection, there is no need to take an antibiotic. So if we practice we are effectively implementing all that will be taught to us, if we implement all that we'll pick up from this diploma program in our settings, in our facilities, in our homes, the first thing that will come up is that we are most likely going to have no new infections come up. That's the first line of defense for IPC with regards to AMR. So if we have effective IPC control measures and people practicing it, we will not have infections. So no need for antimicrobials. Now, if we do not have people taking antimicrobials, what we would have done is to drop the healthcare costs for a lot of people. They just come for preventive checks, and that's it. Now, that's the first line of infection. I'll get to the other one. Now, it will also improve quality. Now, if there, for any reason, in a setting, in a facility, we now have isolated or have identified incidents or cases of antimicrobial resistance, that means organisms that are resistant to our standard and conventional antimicrobials, IPC has another role to play. We've now realized that we have a hospital-acquired infection. So because we have an AMR, if we implement our IPC measures, we will contain, watch my word, contain control the spread. So what it means is that if that infection happened in our high-risk ward, in our ICUs, and the nurses, the doctors, the healthcare workers actively implement the IPC procedures, hand hygiene, watch the way they handle rails, 5 moments of hand hygiene, environmental sanitation, proper handling of linens, handling of sharp containers, and every other thing. What we will do is that we will contain that organism in the ICU. But if we do not practice what we have been taught, what you will have is exactly what we see in our settings, that one single infection at the other end ends up all over the hospital. We have is AMR running over the place, organisms that normally should not get to people that came into the hospital healthy, they end up picking up the infection. So what are the practices that I was talking about that are important to reduce antimicrobial resistance? Remember, I said the focus for most of us here today as healthcare professionals in facilities is to reduce hospital-acquired infections on account of antimicrobial resistant or organisms that do not respond to antibiotics again. So the first one, which I purposely just put bullet points because I know that you have been taking through sessions, is hand hygiene. Now, I'm very keen on having this discussion with a lot of people. Hand hygiene for most healthcare professionals is down there. When I mean down there, I mean most people don't really see it as anything, whether there's running water or not. Most people don't observe the 5 moments of hand hygiene. All they tell you is that, well, I've not gotten on down, I've not come down with any infection, and my patients are healthy. But the funny thing is that your patient might be healthy, but you might have actually helped spread these isolates, these organisms from your ward to other wards, the GOPD, to the high-risk wards, your ICU, people that are immunocompromised. So it's important that we emphasize the role of ordinary practice of hand hygiene, whichever one, alcohol hand rub, whether you're doing your washing with water. It's important to know that when you practice hand hygiene, you break the cycle of emergence of antimicrobial resistance. Let's go on to the next one, environmental sanitation. Yes, I've done my proper hand hygiene, but the linen that I picked up from someone that was used, that had isolate, MRSA, that's an organism that is considered to be very, very difficult to handle because the organism is resistant to the conventional antimicrobials. You pack the environment with things that have come up from those patients. So we go down to the issue we have in our IPC, wastes from our patients. Did you segregate them? Did you just pack all of them and put it in your without using your color coding? So you see the importance of maintaining the IPC. So let me complete the picture. So I take soiled materials, cotton wool, blood, and I put them in something that will normally go out without going straight to the incinerator. What you have is that the environment is contaminated, groundwater is contaminated. That's the same water you're going to pump without disinfecting back to the wards. That's the same thing that you have rodents, individuals, touch, your cleaners make contact with, and they come back and they soil the entire environment. Take a swab one day from your rails, from the ward, your bed handles. You will just realize that, wait, I don't understand. I thought this MRSA or whatever organism that was restricted to this ward has come to this ward. So it's important to know that it's something that is a cycle. You don't do one and leave the other one. You've maintained your hand hygiene. You've not taken care of the environment. You've not handled segregation of waste that's come from your ward. What you have are those isolates that we have successfully taken care of. We end up using them to contaminate every other person, injection safety. So all these things are quite important in breaking the cycle of the prevalence of antimicrobial resistance. Now, I want to come back to why we've bothered to have this lecture. Now, last week, 18th of November down to 24th of November, the World AMR Awareness Week actually was held. This lecture, I believe, is an offshoot of it. So what we we focused on this year was to educate and to advocate and to speak and to insist that everyone involved acts now. Now, this particular World AMR Awareness Week is normally championed by what we call the Tripartite Food and Agricultural Organization. Remember what I said, One Health. You don't just take care of the health facility. If you do not, those farmers will load your poultry with antibiotics. You will come down with AMR because you've consumed suboptimal antibiotics that have been infiltrated into your food. You have the World Organization on Animal Health. You also have the United Nations Environmental Protection. It was the World Health Organization. What is the focus? Let's now go to what is required. I'm going to take a little bit of time and speak. Now, the education we're talking about, you've heard me today. You will ask your questions. You now understand that antimicrobial resistance is a problem that affects everybody. Your relations, your cousins, your family members, your co-workers, the country as a whole. If we have people coming to hospitals healthy and picking up organisms that are resistant and going back home, what we have is people returning with serious ailments. So it will affect everyone. So the message this week is to take this information not just to the stakeholders. When I mean stakeholders, the policymakers, the healthcare administrators, your CMDs, your medical directors, your head of stations, the head of your clinics, not just to tell them, we're trying to tell them this knowledge is not meant to be domiciled in the teaching hospitals or in the facilities. We want to talk to the public. What are we telling them? We're trying to tell them that whatever they do, when they cross and go and pick up antibiotics without prescriptions, they are increasing the burden of antimicrobial resistance. We're telling them that when you load those poultry, birds, and products with antibiotics without recourse to them being important, you are hurting or you're increasing the prevalence of antimicrobials. Then for the healthcare workers, we're trying to tell them that you might not be affected directly by your practice of poor hand hygiene, not taking care of the environment, but it is very imminent for you to know that there are people around you that will most likely get hurt. And you know that when we remember the oaths we've taken, we're not just trying to take care of ourselves as individuals, we're trying to take care of everyone involved, patient relations, co-workers, everyone. So the focus is to educate everyone. You need to tell people. If you do a poll right now about how many of us in this webinar have actually heard of AMR and actually internalized this message, you'd have figures that are shocking. So it's important that we educate. We don't just use the weeks that have been allotted for this education. No, we keep talking about it. IPC is a culture, it's a habit. It's not something that we bring up when we have programs. It's something we T1, just like you said, it becomes a lifestyle. It no longer becomes something we compel you. There's something in my parlance we call legs aphorism. I don't need to lord it over you to say, oh, wash your hand, wear that face mask, dispose that needle well. No, it's meant to be something that is second nature if we continue to educate the public. So we're talking about advocates. What the quadripartite group wants everyone to know is that if we, the policymakers, in whatever position you might find yourself, I know when you hear policymaker, you might say, oh my, I'm not part of them. I just came for this training. I'm not the CMD, I'm not the head of station. Not true. You, at one point or the other, might be the head of a shift. You might, at one point or the other, be the head of a station, or you've actually controlled or had a leadership position in your unit. What we're saying is that we are talking. Advocacy is about pushing a narrative and asking that policies or things be done to help the message. So what's the message? The message to everyone, policymakers, is that we need to stand up and do something. If we continue to leave over-the-counter medications, or medications in the restricted group of antibiotics, if we leave it over the counter, it will come back to haunt us. What it means is that people will use them injudiciously because they don't have the knowledge. So what will we advocating? We're advocating that for us to fight as IPC staff and remain as the frontiers, we need to educate those that are leading whatever place we find ourselves in, whatever capacity. We need to tell them that, can we change laws? Can we try make things streamline regulations that will make sure that whatever we do in this facility would ensure that we do not help in the right incidents of AMR. So what it means in simple terms is that you talk to your unit head, can we make sure that people maintain hand hygiene out here? Can we ensure that our facility water, because when we do that, we will be breaking the cycle of infection at that level. Peradventure, we have healthcare associated infection that is because of the antimicrobial resistant organisms. Can we, in our own setting, insist that proper barrier nursing is done? Can we also insist that people don their protective equipment, insist that healthcare waste is segregated the way it should be gated? Now, when I talk about advocacy, I always love to mention, look at your setting, look at your low-hanging fruits. Do not go and reach out to something you cannot change. Start from where you are. You are an IPC professional. You, by reason of this webinar and the diploma and the training you have, you are a focal person. You have the information. So it is a responsibility for you to insist that things are done in a way that will ensure that healthcare infections because of AMR is reduced to this barest minimum. By that extension, as an IPC staff, you have the ears of the hospital management. You keep advocating. I know we have issues with manpower, but even the ones that are here, can we train them properly? Can we teach them how to don their gloves properly? Can we help them understand the risk they pose to themselves, to everyone in the facility, if they do not obey these instructions? So that's what advocacy for this week is all about. Now, who needs to act? I'm talking to the ones that need to act first and foremost. In our settings, we've been picked as IPC professionals to be trained. It is important that we don't hear alone, that we act out what we've heard. We don't procrastinate. I'll give you an example. I did a posting at a certain point when I went to, I didn't want to mention so that people don't feel stigmatized. I realized that there was no hand hygiene material there, barely running water. I could do, which was a low-hanging fruit, was to use my partnership or my contacts to acquire alcohol hand drops, because that was a word that, well, okay, I'll be very specific. That was a word where could not help themselves. So what I did was get what I could get. I said, please, ma'am, can you help me distribute this? Then I spoke to the person in authority, said, can you help insist that they use it before and they use it after seeing the patient? That's what I could do. In your setting, it might not be that. In your setting, it might be, oh, please, we need to start taking seriously injection safety. We need to stop trashing everything together at the same time. It could be, can we now find alternatives? Can we talk to the pharmacy? Can you help us produce liquid soap? You say, what's that got to do with AMR? You curb the rise in AMR when you reduce the rise in healthcare-associated infections. So you see the connection and you see your role. The IPC practitioners are focal. There's no running away from it. We hold the key to stopping the rise of infection. Remember what I said, if we stop the rise of infection, there won't be need for antibiotics. If there won't be for antibiotics, there won't be any avenue for it to be misused, underused, or overused. What about the administrators? You are an IPC trained facilitator. When you get back to your settings, I thank God for the program. I have an idea a little bit about what is involved. the projects and those things. They shouldn't just happen because you want to get a diploma. The idea, the knowledge, you can approach your administrator that sent you, say, this is what I have picked up. This is what I feel we can do using the resources we have at our disposal, because I like being practical. I don't expect everyone to have, everywhere, alcohol, hand drugs everywhere. No, but we can equally get soap, we can get water, we can get liquid soap. We can actually talk about, can we get the bin liner so that, and we can educate everything to not trash that cotton wool that you used to swab blood into that general container, trash this color bin. That's the focus. So we need to act as IPC practitioners. Our influence will affect our administrators. They too need to act, because I know, let me just tell you the simple truth. Most healthcare facilities are pressed for resources. It's so limited. So if you do not show them the importance through data, because you need to be factual, is evidence-based. IPC is not just the word of the mouth. You need to show them. See, I've seen alcohol, hand drug in the skibo that, or in the ICU, that the rate of infection has dropped by 20%. And your administrator will say, please show me. And the person will take to heart. And most times they work with information. Now, we need talking to ourselves. We need to take this message to the public. Do all you care in the facility. If you don't handle the issues with how the public sees AMR, you will not go anywhere. One, they patronize over-the-counter patent dealers and pick up drugs they should not for any reason be consuming. You have those in animal settings, farmers, poultry workers that have not understood what giving Cipro to a chicken would do to me if I need to consume it. Then more importantly, while we insist on everyone that we need to take this message and keep it domiciled persistently in the public sphere. I always tell people, the weeks, the celebration of World Health Days, they're just meant to be reminders. It's just the way you wake up every morning and you look at the mirror. You need to do something about that spot. You need to keep it in the public sphere. Occasionally, you bring it up. Find the different organizations that can pick it up. Medical Women Association, public health physicians. You can take the message everywhere. Put them on. Now, it's very cost-effective to put out these messages without even spending a lot of money. We need to act. If you don't understand the burden of AMR, what it's doing, come down with infections that basic routine medication cannot take care of. Remember that we are facing economic downturn. People cannot even purchase the first line of antibiotics, which is the access group. Then you're talking about antimicrobial resistance. Now push them over to the restricted group. Now, the problem here is that you have people that will spend out of pocket and will still end. You don't want them. The inexperienced people will still load them with those antimicrobials that will still continue to energize this vision. Now we need to keep the message running persistently. I will conclude this way. AMR is a public health problem. It has far-reaching consequences. It cuts across every crime. It's everywhere. You can't run away. If you've not seen it, you've not looked for it. You have people that are coming down with infections everywhere that your routine first generation cephalosporin, second generation cephalosporin, they can't take care of them. We're all falling into despair of carbapenems. Funny enough, they are actually becoming resistant to their playing with a tool, a weapon, or something that has been there to save us. IPC is focal in the fight to curb the rise. I told you your line of entry. 3, that is first line primary prevention. If I take my message of IPC to the homes, to the public, people will not have infection. People will not need to buy antibiotics. People will then not have any reason to misuse, underuse, or overuse it. We will now have a reduced prevalence of AMR. If peradventure the hospital-acquired infection due to the organisms that are from AMR, they've come up, I have IPC control measures that are able to contain the infection in specific areas, thereby protecting everyone. There's an urgent need to talk. There's an urgent need to educate, but most importantly, beyond educating and advocating, we have to do something right now. Thank you for having me. Questions come around. We need to handle our antibiotics with so much care. Thank you very much. I yield the floor at this moment.
Thank you so much, Dr. Naimika. We really, really appreciate this insightful presentation. Please let's appreciate the speaker. Let's make use of the emoji to say thank you. Let's appreciate. Can we use the chat box? Yes. Thank you so much. It's a very, very timely topic. Like I said earlier, it's actually, it threatens the foundation of we're not able to make appropriate use of antibiotics, which are very, very, very important. And thank you for emphasizing on the need for us to, educate and also advocate and act now. I don't know if you have questions. Please, if you have your question, you could indicate, or you can share your questions in the chat box while I read from there. Do we have questions? Do we have comments? Okay, I can see excellent contribution. Thank you for insightful and wonderful presentation. Okay, please, will we share our questions in the chat box? So for me, while others are writing their questions or noting down the questions, personally, I would like to ask, is there hope for the future in the fight against antimicrobial resistance, looking at the trends and the developments? Let me see if anybody have any question here. Okay, so, let me check. Okay, so what do we, so there's a question here, Dr. Nemeka. The first question says, what do we with facilities, what do we do with situations, so what do we do with situations where infectious patients with PTB, diphtheria, etc. are managed together in the same wards with other non-infectious patients? Okay, so
would you want me to take them attend them as they come?
Yes, as they come. So you give a response to this and then I share the next one. Thank you.
Okay, like I said, we are here today to be trained, to be able to put forward the right narrative. The truth is that there is no way we can, it's not proper, let's not say no way, it's not proper to actually nurse this set of clients together. But that being said, what we are here to do in most settings is to mitigate the spread of the infection. So I have a PTB patient, and my word, if that is open TB, that is a serious issue. What do I do? As I need to look at what are the barriers that can help ensure that those that are not infected are kept uninfected. So you need to talk about protection. So by having a PTB, I'll be very practical. I have a TB patient in that ward. The first thing I should do is, if as much as possible I would want to separate. If I cannot separate them in the ward, what I would do is to bring up the issues of that particular TB patient donning a protective mask. That is the first line. The next line is to ensure that they are not nursed close together. The wards are wide. If they are not wide, you try as much as possible to keep the truth is that it's actually very criminal to do this out thing, but the right thing would be to keep the TB patient isolated totally off, or to keep the person in a place that is well ventilated. That is one line of management. Then for those of us that are nursing them, because the issue is not just the patient, it's also the healthcare worker. When you go to see, you do your rounds, you're moving from highly infectious to moderately infectious to non-infectious patients. Have you actually carried out your hand hygiene? Are you donning your personal protective equipment, your word coats, your face masks, your goggles, your hand gloves? Are you maintaining the 5 moments of hand hygiene? These are the practical things you should do. But the first, I must be very sincere that as an advocate for IPC, you should first of all approach the leadership. If there is any way you can, please try to segregate these patients. That's the honest truth. But if that is not possible, ensure that strict compliance with IPC practices, they're actually maintained in that ward by the patients, by the healthcare workers, and the caregivers as well. Thank you.
Thank you so much. Thank you for that wonderful response. You know, one interesting thing for me in today's presentation is the way you're breaking it down. Like it's so very, very understandable. Thank you so much. So I have a question here that says, what do we do with facilities who don't decontaminate our sewages and farmers, including domestic workers, with this waste? Do I repeat the question?
Okay.
It says,
yes,
what
please.
do we do with facilities? Okay. What do we do with facilities who don't decontaminate our sewages and farmers, including domestic workers that interface with these wastes?
Okay, very important question. You know, that's why I said it's really an issue. When we talk about One Health, if you don't take this message that you've heard here, whatever it is that you've learned today, to the people out there, you would still, by extension, get involved. Just look at the example you gave. We have wastes, maybe contaminated wastes. Our farmers don't mind. We can't afford fertilizers. What do? We can, some waste, they inculcate it into their farms. Vegetables, most people don't want to cook it so long. You have organisms that are resistant to normal antibiotics hanging on your staple meals you consume. You're back into the cycles. What you are to do is to break the line of the spread. I always say, find where you fit in. I might not be able to stand up and say, oh, that sewage truck should make sure it's not taking that to where someone will assess. So what can I do at my own level as an IP staff? All I need to do is that make sure that if there is anything I can do to ensure that very highly contaminated waste don't end up into the public sphere. I give you an example. People just pick up needles everywhere, catch them together. You don't incinerate, you don't take care of them. They end up where people pick things and they pick it up. Now, this waste ends up in your farm and back to you as an end consumer. So your information needs to go not just to the person taking care of the waste. I'm talking about those that clear the waste. It needs to go to the farmers. Do you understand the risk of doing poultry with this waste? Do you understand the risk of farming with this? We have to start something. As we preach the message, is this adhere. We might not have full compliance, but it will help in the long run in combating AMR. That's the much I can say on that right now.
Okay, thank you so much. Thank you so much for that response. While listening to the presentation, a question came to mind. So how can professionals balance the need for appropriate antimicrobial use with patients' expectations and demands for antibiotics? Where do we create that balance, strike that balance? Yes.
Very important, relevant question. You know, the funny thing is that if you look at prescription patterns by physicians, doctors, whatever, surgeons, you just find out that we are as criminal as those people out there. Most of the times, I'll just bring out two terms that we need to look at. There's something we call empirical management. Based on what is in the books, a patient that comes with fever, cough, and fast breathing has most likely pneumonia or, you know what I'm calling, respiratory tract infection. Good and fine. Empirically, respiratory tract infection, I've listened, okay, I've not done a sensitivity, have issue with the lab, I want to treat, and I pick up my pen, and the patient is already telling me, doctor, I have taken amoxicillin radio, I've taken this other drug, and you prescribe, you say, okay, let's climb the ladder, 1, 2, 3, 4. I need to make sure that this patient comes back to me, and you use a heavy hammer and you give your cephalosporin. Good, I'm fine. Most times you might end up taking care of the infection, but most times you'll be surprised that that patient comes back and I'm still coughing, has a viral infection. I'm still coughing. What have you done? You've released an antibiotic and the patient has consumed it, whether in an optimal level or suboptimal level, but you've exposed all the organisms in the body to something they should not have seen at the appropriate time. So where's the balance? As much as we preach empirical management of patients, there's something we call diagnostic stewardship. What it means that if I have a lab that works, if I am sure that I would have a quick turnover with regards to my result, all I need to do is tell this patient, I understand you've taken drugs. This is what I normally preach to them. But you know that at this point, we are not going to be experimenting. You've already done what I should have done down. Let me send your sample to the lab. You speak and explain to this patient. Remember that the profit is not the end product. You should understand that AMR is a real and factual thing. Just take a look at what's happening in our facilities. Most patients are no longer managed. When I went to a facility, what they just told me that every patient that must have come to the hospital must have received all the drugs in the AWARE classification, meaning that some doctors have not actually applied the knowledge that they've gained. So what I'm saying in essence is that do no harm. So what you need to do is stick to what is right, regardless of the economic effect on you. So what does that mean? When it is important to do your empirical management, but when you're doing empirical management, there's something called the AWARE classification. Do not go beyond the access group. Stay there. If the patient comes back down, do your sensitivity and decide whether you're doing the watch group or the reserve group. It's important because the knowledge is what will guide you. If you understand that you don't start with the strongest antibiotics, you should start with the lowest one that can take care of that symptom. So what I've said in essence is that we should do no harm. That's our sworn oath. We need to make sure that we put these patients in our shoes. Imagine you're the one on the other side of the table. What would you have done to you? Thank you.
Thank you so much. Do no harm. Very striking statement there. Thank you for that response. There's a comment here that says there really need to be regulations on antibiotics. Very important. At least I'm aware that in developed countries, there are strict regulations in the use of antibiotics. And then there's a question here that says, please, is there any hope? True. Please, is there any hope for the assessment of primary healthcare centers with regards to antibiotics prescription and consumption?
Okay. I thought there's hope. Like I said, if you read my bio, I just recently I'm affiliated to Shalina. We did a protocol on AMR because we found that it's not just domiciled in the tertiary facilities, that the community and the primary health centers actually in most settings, those communities to do sensitivity. So we need to take this information to them. So the truth is that the message, both from NCDC, from many pharmaceutical firms, the European Union, people are seeing the need to take this message. So if I can preach to the man on the street, the primary healthcare centers are not left out. I know that we have protocols for management of patients in primary healthcare centers because we don't have the established lab. So there's hope, actually. Like I said, if everyone out there, I'm talking about the patent medicine dealer, I'm talking about the end consumer, understands that that drug I just took over the counter can be the ruination of my life, my family, or the community. And that message continues to resonate. And like someone said, regulations starts to kick in. I don't expect them to come up. Remember, when we talk about regulations, we're talking about both regulations for the pharmaceutical firms and for the patent medicine dealers, but we're also talking about regulations in the hospitals. Because the funny thing here is that you see people that should not, like the reserved group of drugs in other climes, the way it's done is that you cannot prescribe any drug, any carbapenem, without getting clearance in most settings. There's hope. We are building this knowledge, and that's why this webinar is important. You are the champion of this knowledge. You change one life after the other. Speaking to your colleague, telling them that AMR is effective, AMR is rising, that, AMR mitigation, IPC controls are effective in breaking the chain of infection, that you can contribute a great deal to stopping AMR yourself. Very simple. In your facility, say, please do not prescribe this drug unless you are aware of the sensitivity or you have this protocol. So there's hope. The message is getting pushed out. But what I know we need to do is do more. We need to keep it there. Don't just make it a health week thing that once it comes up, we just know. This message should stay there. IPC practitioners is something that is totally and very critical in handling AMR. There's hope. We've, like I said, the affiliations, they are actually the protocol. We decided to start with the facilities. You do the tertiary, you do the secondary, and you do the primary health centers, because it's very important, because most of the times they are the ones that educate the patients on what to get. Thank you.
Thank you so much. Thank you so much for that wonderful response. I don't know if there are more questions. Okay, yes, I see one. It says, I think, okay, maybe it's a comment. It says, I think IPC and AMS is poorly pushed in our hospitals. But what measures in terms of policies and regulations by Ministry of Health and NCDC can be done to strengthen these aspects in our facilities?
Thank you very much. Well, I was able to get into the webinar today because of someone I had contact in that came to do inspection for a facility with regards to IPC. And prior to that, I had people from NCDC come to my facility. The truth is that AMR is a public health problem that is getting gradually publicity. But the truth is that we have the people that will push out the message listening to me today. They are working on policies, but I always tell people, policies are policies. You need to enact, domicile it, and practice it. There are big, highfalutin policies that are out there. They are very effective if implemented, but in most settings, they don't have what it takes to implement it. So what we need to do, and that's the take-home message to my IPC practitioners that are here, is that you look at the message of AMR. Which of these low-hanging fruits can you take home and implement? Which of them can I take home to break this? NCDC can do their policies. It will take time before we get that ceftriaxone outside the hospital. It will take time. They will receive a lot of, you know what farmers do, big pharmaceutical companies do. It will be difficult, but it's possible. So as for policies, NCDC is working on it. Many organizations message out there. Like I said, I've had the opportunity to visit facilities where I spoke about AMR and IPC. Like I told you, in some settings, they are entwined. In some settings, the committees are separated. But by and large, you cannot separate. They are just more like Siamese twins. And IPC is key to combating or mitigating the effect of AMR. So in conclusion, these strategies are very, very practical, but you need to pick up on the one you can do. While NCDC works from top down, you work from down up. Thank you.
Thank you so much. Thank you so much, Dr. Nnameka. I'm not sure we have more questions. So I'm also thinking about it in my mind that there are actually several social determinants of health that is actually impacting our efforts a lot of people are not enlightened. I mean, the public now, not IPC professionals. I'm referring to the general public. So we're used to seeing people popping antibiotics, into their mouths. They just can't get it, access it anyhow. So it's actually really impacting our efforts. I don't know. So generally, what do you think, we can do differently? Apart from enlightening the next door neighbor beside me, are there extra efforts that we need to do?
Yes, like I said, it's a multidisciplinary effort. There are many key players in the fight for AMR. You can enlighten your neighbor, but the regulatory bodies for the farmers, the regulatory bodies for the pharmaceutical firms, they need to step up and do their work. I'll give you an example. If I ask you to check your neighborhood, you would realize that the pharmacies that should maintain 500 meters between them, they are close by. But in between those pharmacies, you have about 10 or 15 patent medicine dealers that should not have in their custody drugs that they are marketing. It's not regulation. We're not even envisaging it. We're not doing anything about it. So what I'm saying, but we should also show them examples of where carrying out this message has worked. I always tell people, give people live examples, evidence-based examples. Go to your this thing. I picked up a sample of meat from the market. I've not done anything, and I send it and to have toxicology done and see the titers of antibiotics. You put that out. You've educated them, but it's now left for the organizations that regulate this to say, please, we will not have you people use this any longer. But the funny thing here is that it's not a one-man show. It needs concerted effort. Education is the least we can do. We need to advocate that these policies that we are pushing, that they are implemented. I want to tell you, go to the UK and elsewhere, you don't source these antibiotics there. So that's the government holding their own end. Come to the healthcare facilities. Before in senior clients, before you acquire, you prescribe a certain class of drugs, those in the watch classification, you must get clearance. That means pre-treatment and prior treatment. So what I'm saying is education is what we can do, basically, but we need to act these things out in our settings and in research and show people, see, we just decided in our skibo to put running water. We've decided that before anybody in this skibo comes in, the person must have done a face mask. We've decided that going forward, that nobody in this health facility will prescribe a carbapenem without getting sensitivity. You study it over time and you put out this message that people see this is true, and you give examples of how these things have worked in your setting. I'm not talking about teaching hospitals alone, I'm talking about primary care settings. Bring everybody, let them be the ones preaching the message, and hopefully we'll win this battle against the AMR.
Thank you so much for such a wonderful presentation. Please, let's appreciate our speaker. Let's use our emoji team. Thank you so much, Dr. Nemeka. And before I forget, I also want to apologize for the, yes, I can imagine what it felt like, trying to have a sex and, it wasn't really going.
Yeah,
really appreciate
it was difficult, really.
Yes, I really understand. Apologize for that, and hopefully we believe that in next sections that we're going to have ahead is going to be a seamless process. Thank you, and we really appreciate you for sharing your skills, knowledge, insights into this wonderful and important topic. And I pray that the world will be able to combat this issue, this public health issue. Thank you once again. Thank you once again. And thank you to good to have you. And thank you to everyone who took out time to participate in today's section out of a very, very busy schedule. You must agree with me that it was a wonderful section. Personally, for me, it was wonderful. Actually, interesting to me is how he was able to break it down in a very easy way for us. I would like to take the opportunity now to share an important information with everybody. So I'm going to share my screen. Okay, just hold on. So. Okay, so please confirm that you're able to see my screen, everybody.
Yes, we can actually.
All right. So what we have here is the anticipated National Conference on Infection Control. I'm sure some of us are aware of the upcoming conference. We've always looked forward to it for 2024. And we have a very good topic here. Yeah, the theme is strengthening infection prevention and control in Nigeria. And we have our sub-teams, and when you look closely, you can see interesting sub-teams that we have here. It's going to really be a very wonderful conference. I believe it's going to be eventful and also very impactful. And I'm hoping to see everyone here that is in this section. So now, the good thing is that it's a hybrid event. So for some of us who are not based in Lagos, who might not have that time to come physically to attend, yeah, so you'll be able to join virtually. And then it's happening 4th to 6th of the next month at Orchid Hotels Limited in Lekki, Lagos. I look forward to having everyone here, because one of the interesting things that we're going to do is that there is going to be a workshop, participatory, for 2 workshops. So the first one is sponsored by participatory approach to learning in systems, interprofessional collaboration in improving IPC practice in healthcare facilities. And then the second one is sponsored by JNCI. It says effective sterile reprocessing, a means of strengthening infection prevention and control practices. We have the chairman, Dr. Jide Idris, that's the DG of NCDC, and our able keynote speaker, we are all very familiar with, Professor Folashade Ogunshola. So it's really going to be a power-packed conference. There will be plenary sections. We're having partners in IPC in attendance, and I would love to see each and every one of you see. So now you could join virtually, you could join physically. If you can do that, it would be great. The registration is ongoing, and I would like to encourage each and every one of us to secure our seats. Yet the early bird registration is still ongoing, so you have the opportunity to register today. Don't procrastinate so that it doesn't become late registration. For the students who are part of this forum, yes, you can also register, and we have international participants. The fee is also there. Now, when you go to the chat box, I don't know if there are people who are joining the ECHO section for the first time, and you would like to become a member of NSIC. You're not a registered member of NSIC, but you would like to be a member. Okay, so let me stop sharing the screen now. So when you go to the chat box, you're going to see the link that I shared there. Did we see that link?
Yes, we can see it, ma'am.
Okay, so the first link that I shared is how you can become a member of NSIC. There are so many benefits. So now let me mention that when you become a member of NSIC, you also automatically become a member of ICANN. So how it works that, so ICANN is the parent body. That's the Infection Control African Network. So when you pay to NSIC, your payment also covers that of ICANN, and it's just a token of 10,000 naira. So directly to ICANN, you have to pay. So now registering with NSIC gives you 75% discount. 75% discount yet. So the form is there, the link is there. Click on that link and share your details with us. I will follow up with an email so you can know how you can then make your payment, and then we'll share your membership or certificate with you. Now, the second link that I have there is how you can, register for the conference. You can register for the conference, take advantage of that. And then we had also shared information on how people can, share their abstract with us. I think today is the deadline for submission of abstract, or tomorrow. So if you have an abstract, you want to share your insights, important information about IPC, advancing IPC in Nigeria, Please do well to share that abstract with us, possibly today or latest tomorrow morning. We can give that window. And then I look forward to having every one of us here. You could join virtually. It's going to be a wonderful time together next week. And I do want to see every participant here in the conference. I look forward to your inquiries about the conference and also every other relevant information. Thank you once again for joining today's section. Like I said earlier, it was organized by ICANN West African Hub in collaboration with CCAPS and NSIC, Nigerian Society for Infection Control, through the ECHO platform. I'm really, really happy to have everyone here. And I look forward to seeing you in subsequent sections and also, most importantly, next week in the conference. Thank you so much and do have a wonderful day ahead. Thank you to our presenter, our facilitator, our speaker, Dr. Nemika. Thank you once again. Thank you once again.
Thank you for having me. Thank you
All
very
right.
much.
Okay. All right. Please, I look forward to everyone clicking on that link and then, registering. I want to see everyone in that conference. Thank you so much and do have a great evening ahead. Bye.
Thank you, ma'am.
All right.
Thank you and bye.